Reed here. How's it going, everybody? Welcome to this new episode. This today's discussion is going to be on diffuse traumatic brain injury. But first, let me get rid of this previous banner here. Let's see here. Okay, let me get rid of that. Okay. And so the name of this discussion is about diffuse traumatic brain injury. And we're going to discuss how to identify, how to assess, and how to document, and how to treat diffuse traumatic brain injuries. Now, diffuse traumatic brain injuries are a challenge in and of themselves. Why? The brain is encased in this bony cavern, and you can't see it, right? Well, you can see it with a CT scan, but when you're first assessing the patient, um, you can't see the injury. So what you have to do is you have to listen to what the patient is saying. So if the patient is saying things that suggest that they have a memory problem, then you think it's the hippocampus, right? If you think the patient is having, perceptual disturbances, like they interpret reality different than you, or their reality is so different that you can't understand how they came to that conclusion, that may be the prefrontal cortex. If they start having like impulse control issues, attention to concentration issues, planning problems, then that may be the frontal lobe. So even though you can't see the brain, for a person who's experienced a significant head injury, you can sort of listen to them and examine them to sort of see the areas that are most likely impacted. If you understand the networking and the blood supply and things and what that area is responsible for, then you'll probably get a good idea of what you're going to use as medications to help treat. So, for example, if the patient's hippocampus is malfunctioning or is damaged and they're having difficulty with memory, of course, you want to use the medication to help the patient with memory issues like Aricept, memory medications, right? If the patient is having rage attacks, secondary to damage in their temporal lobe and things like that, something similar to temporal lobe epilepsy or word finding, speaking difficulties, then you think that's the temporal lobe. And you may want to put the patient on something like a mood stable, like Depakote, to decrease all of that seizure-like activity in that in the temporal lobe that's creating all the agitation and aggressiveness. If their frontal lobe is hypoactive and they can't pay attention to concentrate, you may want to start a stimulant, right? If they're having psychotic symptoms like hallucinations, delusional, disorganized behavior, you may want to target, you may want to prescribe an antipsychotic because it would block all those dopamine pathways, right? So with a diffuse traumatic brain injury, that means, imagine like a motorcycle accident, right? Inside the brain is a sponge and it batters back and forth inside this cage, creating coup and then contra coup injuries, coup and then contra coup. Coup when it hits forward, when the brain hits something, the skull hits something, the brain moves forward and hit the interior wall, interior surface, the interior part of the brain in this coup injury. And just like the sponge, it is that wave ripple back and it can hit the posterior aspect of the skull called a contracoup injury. And you can get injuries flipping over on the motorcycle, rotational stalk injuries, hyperextension, overextension, rotational injuries. These rotational injuries could be very damaging because you're stressing these structures that are right there at the stalk. So you're stretching all of these structures and you're interfering with these huge bundles of fibers that go and do things. And so those rotational like injuries can be very devastating, right? So what we're going to do here is let me search. Let me search something. Let me see. What am I searching for? Okay. Let me do all these things. Okay. let me go ahead and search, explain explain the assessment. Okay, explain the assessment and treatment of diffuse traumatic brain injury. Oh my. Let me see what they have here. Oh, let me go through this first. Pretty good example. Yep. Pretty good example here. See, I get all mine for free. I just go in and get out. Go in and get out for free. Okay, here's the wall. Okay, here's the brain pushing forward and hitting the internal surface of the skull. And just like gelatin, it pushes, comes back, and you can get a second injury when the sponge hits the back injury of the skull. Now look at all of these layers here that becomes disrupted. Look, this is the axon shear here. At that differentiation between the gray and white matter here, the severing can occur at this point, severing the neuron in half, right? This is very dangerous, and it can occur in multiple locations. Why is this dangerous? Then the damage and the death of the cell leads to a loss of all of the content in that space. And so you get the release of all of these molecular molecules in that place and all of in this space, and all of these things do things. They're all active. So the content inside of the cell is considered more toxic outside of the cell. You don't want all those things outside of the cell because they're very active. You have a factory with no windows and no doors, right? And remember the rotational stalk injury? Yeah, that shearing effect, that shearing effect can be very dangerous. Let's see here. Okay, this is great. Wow. Hey, look at this. It's great. Diffuse axonal brain injury. Hey, all right. Injury attorneys. You mean that I got to get my reference material from injury attorneys? No, I'm not doing this. I'm not getting my material from an injury attorney. No, the stuff is nice. His or her stuff is really nice. Okay. Anatomical justice. Is this another legal site? Man. Okay, you'll see anatomical justice. Okay. Whiplash. Here, subdural hematoma. Right? A subdural. So this gray part, okay, yeah, the gray part there is the subdural hematoma. Look, here's your dura, brain, the skull, the bridging brains. I can't really see them that well, but it serves its purpose. Look here, you have subdural hematoma. So the effects of diffuse traumatic brain injury on the brain cells. Great. Axonal shearing occurs during hyperextension or hyperflexion injuries. Okay, shearing. Axon terminals pulled away from synaptic junctions. Wow. Wow. That's the first time I've heard of that one. Of course, the axon and the axon terminals. Okay. And here's the shearing. Oh, okay. They say retraction ball here. Necrosis of the cell body and dendrites. Yeah. And then when the cells die, they're not replaced, right? Then there's an entire process that takes place after the cell dies. In order to clean up all of this, you have your immune system that picks up the damage, and then it starts to recruit it recruits an inflammatory response, which recruits more of the white blood cells to sort of help manage this thing, help clean this place up. In order to increase the inflammation, it has to make the blood-brain barriers porous. And because the blood-brain barrier are porous, now you get the state of sort of confusion and sort of like a diminishing storm, difficulty focusing, difficulty concentrating, difficulty thinking, because that inflammation, the inflammation interferes with how all the networks function, because the inflammation makes the blood-brain barriers porous. The blood-brain barrier is supposed to be semi-porous. It's a semi-permeable membrane, meaning it only lets specific items through. However, after the inflammatory response to an injury such as this, it must increase the inflammation in order to get the immune system there, in order for the immune system to start to react to this event. And the inflammation itself causes dysfunction with the neighboring circuits around it. And the inflammation itself can also promote and encourage more brain cell death. So the death of the cell leads to the death of the cell leads to worsening inflammation. And that inflammatory response, although it's there to help you, it also causes damages also. This is a tough situation to be in. Anatomical justice. Let me get off this page. Why do the attorneys have better diagrams than the doctors? Let me look here. Oh, these are for sale. Those are, let me get off the attorney website. All right, so here. Okay, then let me look here. What is this? Classification of traumatic brain injury. Okay. Okay, types of brain injury. Diffuse, and this I'm talking about here. Focal, right? Diffuse, a concussion. Remember a football, a helmet, a foot getting knocked unconscious with football, falling off a motorcycle with a helmet, right? Diffuse axonal injury, the blast, right? Abusive head trauma, shaken baby syndrome. Yeah, head trauma, shaken baby syndrome, a blast, a diffuse axonal injury, and a concussion. So these are all the different things that can create a diffuse traumatic brain injury here. And then focal, like contusion, get hit on the head with a ball, penetrating gunshot wound. Epidural, right? Then you can get a hematoma located in the epidural space, the subarachnoid space, or subdural. So, but these are so a hematoma could create a focal injury because it can still lead damage to the tissue, like intravesicular, hematoma, also intracerebral, intraparenchymal. And so these are all the focal subtypes of a diffuse traumatic brain injury. Yeah, this thing is helpful. Okay, let me see here. Okay, here. Diffuse traumatic brain injury, especially diffuse traumatic axonal injury, is assessed by monitoring vital signs such as the Glasgow Coma Scale. Oop, hold on one second. Telemarketer. Okay, yeah, the Glasgow Coma Scale, right? Performing neurological evaluation and using images like CT scan or MRI to check for widespread damage. And you want to see inflammation, right? Treatment focuses on preventing secondary injury by optimizing oxygen levels, maintaining blood pressure, and managing intracranial pressure. Long-term care involves a multidisciplinary team of specialists providing physical, occupational, speech, psychological, and cognitive therapy to help the person regain function and return to a normal community. Just look at these areas: long-term care, multidiscipline, right? Specialists, okay. Physical therapy, getting in shape. Occupational therapy, learning how to work around the house. Uh, Occupational therapy, learning how to get around the house, speech therapy, because it can be in the area of age for speech, psychological, right? Because it can be in that prefrontal cortex, affect your perception of things, cognitive, it can be in your frontal lobe. And so this multidisciplinary team will focus on the different aspects of the person's care. Um, let's look here, the assessment, the initial pre-hospital evaluation session, of course, vital signs. Look, Glasgow Coma score, a score out of 15 to assess the level of consciousness. Now, the higher the Glasgow Coma score, the likely the severity, the severity of the symptoms associated with the diffuse traumatic brain injury. So, if a patient had like memory loss, like if they had a diffuse traumatic brain injury, and you're talking to them a month later, you say, okay, well, do you remember the events that led up to the accident? I don't remember. Retrograde amnesia. Well, do you remember what happened when you woke up in the hospital? Yeah, I woke up in the hospital. My mom and pop was there, and we were talking about things and everything like that. So no anterior grade amnesia. So with the diffuse traumatic brain injury, look for the retrograde amnesia. Did they remember the things before the accident, or the anterior grade afterwards? And so, great. Next, pupil examination, pupil dilation. See if those those tracks are functioning well. Get the patient history, gather information about the injury, and if consciousness was lost. Okay. A medical evaluation, so of course, neural exam, CT scan most likely, blood tests. Right. If they come in confused or agitated, you're going to need blood tests to see what's going on. Right. Treatment, acute and supportive management, and then long-term rehab. Look, oxygen and ventilation, stabilize the blood pressure, prevent other problems by managing everything correctly, right? So you don't want a fever, you don't want high blood sugar, things like that, Long-term stability. Again, the multidisciplinary treatment approach, physical therapy, right? Occupational, getting around the house, speech, communication, cognitive, alertness, awareness, psychological counseling, support, vocational counseling, basically start getting, being able to assess the person's skills and sort of help him get back to work. Here, now let me see, explain the Okay, let me see if of course, the treatment is going to be whatever's in front of you. Basically, you're going to have to put together a combination of medication to make things work right. Medications for diffuse traumatic brain injury target specific symptom complications, including anticonvulsants for seizures, particularly if it's in more of the temporal lobe where there's intense anger, diuretics to reduce intracranial pressure, pain relievers and headaches, antidepressant if they're very depressed, anti-anxiety agents. But with diffuse traumatic brain injury, I recommend try to stay away from narcotics because they have difficulty controlling the impulses. So if they start using a narcotic, then they may not be able to stop because they don't have the frontal lobe power to suppress that impulses. Does that make sense? And stimulants to improve alertness and focus. Other medications include muscle relaxants, anticoagulants, and medications like amantadine for cognitive and behavior issues. Okay. Medications for acute symptoms, such as medications for acute symptoms and complications, diuretics, lead that to the other team. You have your anticonvulsants. I prefer Depakote, anticoagulants. We leave that to the medical team, osmotic agents, the medical team. Management long term, yep, same thing. Okay. Let me look here. The choice of intensity of medication depends on the type of severity. Let me look and see if they come in anything on the severity of TBIs. What type of TBIs are medications? Medications administered for traumatic brain injury depends upon the type of injury, its severity, and results. Functional impairment medications also vary on the stage of treatment, which includes acute phase of treatment immediately after the injury and a long-term management complication of chronic symptoms. Okay, so same thing. Osmotic agents decrease the height of pressure, anti-convulsion. Make sure their electrolytes are bound. Um, Now, look at this. Um, NMDA receptor antagonist. NMDA is a type of glutamate receptor, and glutamate is excitatory. So they want to not use anything that's going to excite glutamate because that's going to make it more hyper. We want to go with we want to reduce it. So barbiturates, I wouldn't use those. Long-term managed stimulants because you may need to stimulate the frontal lobe. If the frontal lobe is in hyper, if the frontal lobe, just like if the frontal lobe is damaged and it's not as active, then you have less executive functioning symptoms. You become more inattentive and easily distracted. That's why in children with ADHD, we give them stimulants to stimulate the frontal lobe, not to stimulate the whole body, to stimulate the frontal lobe to become more active. So the frontal lobe processes more information, and therefore the patient reacts because they're processing more information. So that's what the stimulus is for. Now, remember, dopamine antagonists. Remember, the diffuse traumatic brain injury can damage the major pathways. If you get damage to the mesocortical pathway, it's going to bounce up and down. When that mesocortical pathway bounces up, you're going to get positive symptoms. When it bounces down, when it becomes hypoactive, you get negative symptoms. And so during the day, if the diffuse traumatic brain injury, let me show you what I'm talking about here. Okay, mesocortical pathway. Just look here. This pathway here, come on, give me for free. Come on. Give it to for free, yeah. Y'all can get it for free. It's educational purposes. So this is the major nerve bundle in your brain called your mesocortical pathway that's primarily responsible for the symptoms of autism and schizophrenia. If the diffuse traumatic brain injury damaged this root at the stalk, then the entire network becomes unstable, meaning it's no longer regulated, meaning there are times when the network becomes hyperactive. When this mesocortical pathway becomes hyperactive, you get positive symptoms of schizophrenia. When it becomes hypoactive, you get negative symptoms. And so an injury, diffuse traumatic brain injury, can switch this network on and off. And so the patient presents agitated, psychotic, then withdrawn and apathetic and avoidant and things like that. Now, that's just that pathway. And look how far it extends all the way up here to the frontal lobe. This pathway right here, the mesolimbic pathway, is the pathway of target for all the drugs of abuse. Hyperactivity in this creates the intoxication that every cocaine person who's addicted to cocaine uses. So the addiction to cocaine is secondary to the need to keep activating this mesocortical pathway. Now, during drug withdrawal or cocaine withdrawals, they typically have the exact opposite symptoms. The fatigue, the anhedonia, decreased interest, decreased motivation. You get injury to this mesolimbic pathway, it'll be hard for the person to experience your pleasure, dysphoria. They'll keep popping back and forth, happy, sad, it's just to be a mess. And so you can see how the diffuse traumatic brain injury damaging these major nerve bundles can create complications due to overactivity and then suddenly hypo or underactivity. And take that throughout all the networks in the brain. And there you see the complexity in treating diffuse traumatic brain injury. So what I do is sort of like look at the area of the brains that's not working well. If it's not the hippocampus, if the memory is not working well, then we need to work on work on the hippocampus. If their perception is off, we need to work on this mesocortical pathway. If they seem like they're withdrawn, hypoactive, no interest, motivation, we need to pump up the mesolimbic pathway. So I sort of look at these different parts of the brain and the pathways to sort of try to figure out a way to stabilize all of this symptomatology, right? And so things like Depakote mood stabilizers are always used first, and then try to target the hippocampus with things like acetylcholine and increase the acetylcholine in those parts of the brain. I think that's all I want to say here about diffuse traumatic brain injury. Um, and if you have any questions or anything like that, please feel free to put them in the comment. If not, yeah, it's a pleasure talking to you. Take care, guys. Read out. Ciao.